Hello and welcome to the case-based educational curriculum in emergency medicine, presented by Stanford Emergency Medicine International, URC, and with funding by USAID. This presentation is on how to do an electrocardiogram, or ECG. What is an electrocardiogram, which is also called an ECG or an EKG? An electrocardiogram is a picture of the electric signals for the heart, not the heartbeat itself. So an electrocardiogram is an image of the electricity that courses through the heart to cause it to have heartbeats, but it is not an image of the actual movement of the heart itself. What do the waves on an EKG mean? Well, let's look at them more closely to get a better understanding. This is a picture of two complete complexes of waves on an ECG. The first wave in the complex is called a P wave. It's the flatter, usually pretty short wave at the beginning of the complex. It is the electric impulse that causes the atria of the heart to contract. So it is the electrical impulse that causes the very beginning of a heartbeat. The next complex is called a QRS complex. It is the narrow complex that is representing the electric impulse that drives ventricular contraction. So that's the contraction that pushes most of the blood out of the heart with every heartbeat. The last wave is called a T wave. Usually it's a little longer and a little taller than a P wave. A T wave represents ventricular repolarization. When a QRS complex happens, the heart depolarizes many of its cells in the ventricle. And in order to have enough electrical capacity for the next heartbeat, the heart itself has to repolarize since it depolarized. And that repolarization is what a T wave represents. Putting all of this together, we see that a P, QRS, and T wave are together the electrical impulses that cause one heartbeat to occur. And as you can now see, the image on this slide depicts two complete cycles of electricity coursing through the heart to cause a heartbeat, and then that depolarization being followed with a repolarization represented by the T wave so that the whole process can start again. So now let's talk about what symptoms should make you order an ECG. What I'd like you to think about is what sort of chief complaints in patients coming to your emergency department should make you think that you need a test that looks at the electrical impulses of a patient's heart. Okay, have you thought of a few? Let's see if the symptoms you were thinking of are the same symptoms we have on this list for this slide. The classic symptom for which you should always order an ECG in patients who are at least 18 years and older is chest pain. Remember that there are many forms of chest pain: sharp, dull, throbbing, pressure-like, and that many of your patients coming to the emergency department will not identify pressure as chest pain. So please ask them two questions. Are you having chest pain, and are you having chest pressure or tightness? If you ask the question in this way, you'll get all of the patients with chest pain to tell you that they have it. If you don't, you may miss a few. And that's dangerous because some patients with chest pain, of course, are having myocardial infarctions. Myocardial infarctions are a condition where patients have inadequate flow of blood through the coronary arteries into their heart. The lack of blood supply leads to death of the cells that make up the heart, the myocardium. Now, there are two general types of myocardial infarctions: ST elevation myocardial infarctions and non-ST elevation myocardial infarctions. I'm going to talk briefly about both. An ST elevation myocardial infarction is a myocardial infarction where, in a few leads on an EKG, you can see elevation or rise in the S wave to T wave line, the line that connects the S at the end of the QRS to the T wave. There are also myocardial infarctions that have non-specific EKG changes associated with them or no changes at all. Both of these types of myocardial infarctions are called non-ST elevation myocardial infarctions. So please order an EKG on patients with chest pain because some of them will have very clear changes that are specific for myocardial infarction, ST elevation myocardial infarctions. So now let's move on to the next symptom that should make you order an EKG. Palpitations. Palpitations are the sensation of your heart beating. Patients actually feeling their heart beating in their chest. It's unusual, but it is something that everyone experiences at some point in their life, and sometimes when this occurs, it is associated with arrhythmia. Arrhythmia means an abnormal rhythm or pattern of the beating of the heart, an abnormal set of P, QRS, and T waves, either in their speed or in their shape. So, these types of arrhythmias are very important because they can be associated with morbidity and mortality, and many times if you identify the arrhythmia, you can make interventions that can prevent disability and in many cases also prevent death. Some of these arrhythmias are atrial fibrillation with rapid ventricular response, that's what RVR means, supraventricular tachycardia, and ventricular tachycardia. Ventricular tachycardia is where the ventricle itself is rapidly beating on its own, and the QRS complex, instead of being narrow, is very wide. Now, I'm only telling you this not so that you can identify each of these, but so that you can be, in a general sense, familiar with the concept that a change in the shape of the waves on an EKG from their usual pattern may be associated with something dangerous. And of course, we encourage you to do further reading on your own about these types of arrhythmias so that you can identify them on EKGs. The next symptom that should make you think to order an EKG is syncope. Syncope is loss of consciousness. Patients lose consciousness for many reasons. However, some of those reasons are myocardial infarction and arrhythmia. So if a patient has syncope and you have an EKG machine, it's a good idea to look and see whether or not they've had a myocardial infarction and whether they have any of the arrhythmias we mentioned above and some other arrhythmias. For example, the four listed on this slide in this section, Wolff-Parkinson-White, hypertrophic cardiomyopathy, and Brugada syndrome, in addition to long QT syndrome, all can cause syncope and all can cause sudden death. So identifying those arrhythmias in patients presenting with syncope may give you the opportunity to make an intervention that could change their life and save it. The last symptom we'll mention here as a reason to order an EKG is dyspnea. Dyspnea is shortness of breath. Now, shortness of breath has many causes, just as all of these symptoms do, but some of those causes are cardiac. Myocardial infarction and arrhythmia don't necessarily have to, but can cause shortness of breath. So again, if a patient comes in with chest pain, including chest pressure, palpitations, syncope, dyspnea, order an ECG. It may not identify something abnormal, but if it does, that could be important in helping you determine the diagnosis and making an intervention that can improve or even save the patient's life. Now let's talk about the parts of an ECG machine. The first part you should be familiar with are limb leads. One for each ankle, one for each wrist, 4 in total. Then there are precordial leads. There are 6. They go on the chest. The third thing you should know is the on button. and the cardiac monitor screen. The on button and the cardiac monitor screen are in different places on each machine. The ECG paper roll and the start button that begins the printing of an ECG, which you see coming out of the machine here and being analyzed on this slide. Now let's talk a little bit about how to do an ECG. The first thing you want to do is position the patient properly. Here we have a patient coming into the emergency department. He's being directed to lie down. You want to have the patient lie supine with their shirt off and with all bracelets and anklets off of their body. You also should be familiar with the location or position that you will put each lead on the patient. The left arm, the right arm, the left leg, and the right leg together comprise the limb leads. V1, V2, V4, V3, V5, and V6 comprise the precordial leads that are on the chest. Notice that we mentioned V4 before V3 because typically the order in which you place these leads is V1, V2, V4, then V3 between V2 and V4, V5, and V6. The reason for this will be very clear in a moment. Because the leads are in particular positions, each EKG line created from those leads details a different part of the heart. So for example, this is a large EKG. They may of course have different formats, a long strip, a big page as you see here. The information will always be the same, just laid out differently. You see that this EKG has different identifications of each line: 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, and V6. 12 lines in all. Now let's talk about the different parts of the heart that each line corresponds to. What are the regions of the heart on the EKG? V1 and V2 are the septum of the heart, separating the right from the left sides of the heart. V3 and V4 are part of the anterior sections of the heart. The electricity coursing through these regions is coursing through the anterior portions of the heart. 1, AVL, and especially V5 and V6 are associated with the lateral sections of the heart, typically associated with the left side of the heart. 2, 3, and AVF are associated with the inferior portions of the heart, typically associated with the right side of the heart. And AVR is associated with the region of the right ventricle through which outflow occurs, and also to some extent the base of the septum. Now let's talk a little bit about placing the leads with some video instruction. First, move the machine to the patient. Notice that the leads are connected to the EKG machine. Make sure that all of the leads that will be connected to the patient are connected to the EKG machine. Place the left arm limb lead. Place the right arm limb lead. Place the left leg limb lead. Place the right leg limb lead. Find the fourth intercostal space when preparing the first V1 precordial lead. When you find it just to the right side of the sternum, place V1. And then on the left side, on the opposite side, place V2. also in the fourth intercostal space. Now, the next step is to place V4 at the midclavicular line in the fifth intercostal space. Notice that the nurse is taking her time to place the lead properly. After you place V4, you want to place V3 on the fifth rib between V2 and V4. You will make a diagonal. Next, place V5 at the anterior axillary line again at the fifth intercostal space, which is the space just below, not at the nipple. Finally, you want to place V6 at the mid-axillary line. Again, fifth intercostal space, in line with V4, V5. Now let's talk about operating the machine. First, turn the ECG machine on with the on button. Then, check the monitor. Check not only that the monitor is turning on, but also that the heart rate is declining, as it will initially look a little faster than it really is, and that each lead is picking up a signal with a QRS. Then, open the roll box, make sure there is a paper roll in the box, pull that paper out so the edge is outside the roll box, close the lid, and press the start button. The start button will cause you to print the ECG, which you see coming out with 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. And then on this particular machine, an example of a complete PQRST complex from each lead, and then the computer's own interpretation, which is not necessarily right. Confirm that you have clear lines for all 12 ECG leads, and interpret the ECG. It's a good idea to ask for your colleague's opinion about what the ECG shows. What sort of rhythm is present, and is anything abnormal? The ECG's interpretation can be wrong. Please trust your own interpretation more. Now let's talk about some pearls of wisdom. What can you see on an ECG? This is a little bit of a review and some new stuff as well. Arrhythmia, myocardial infarction. You may also sometimes see evidence of toxins or abnormal electrolytes, as they can change the way that the heart rhythms occur. Aside from patients with chest pain, palpitations, syncope, and dyspnea, which patients should have ECGs? Patients with altered mental status, because toxins and electrolytes produce particular predictable patterns on an ECG. If you learn to recognize those patterns for toxins like organophosphates or certain types of abnormal electrolytes like hyponatremia or hypo or hyperkalemia, then you can identify a reason that you can take action on for which the patient has altered mental status. When should the physician look at the EKG? The answer is immediately. Even if the physician is on break, the physician needs to look at the ECG immediately, because all of the things we're talking about as potential diagnoses we can see with an ECG, arrhythmias, myocardial infarctions, toxins, abnormal electrolytes, these are very, very dangerous conditions that require immediate action to prevent disability and to save the patient's life. In other words, the ECG could reveal to a trained physician the presence of an emergency. So the physician needs to see each ECG immediately to see whether or not an emergency is present. Not every patient who is very, very sick looks very ill. Pitfalls. Let's talk about some potential pitfalls. For example, putting the wrong leads in the wrong places. This is, of course, easy to do. You prevent it, of course, with practice, reviewing this video to make sure that you position all of the leads in the correct places. but you should always double check your anatomy to ensure the right position. If you don't do so, putting the wrong lead in the wrong place could lead to an ECG that doesn't make any sense, or one that misleads you into thinking that a patient is more or less sick than they actually are. Another pitfall is placing leads without good skin contact, including good suction for those precordial leads V1 through V6. ECGs have to be in contact through their leads with the skin, or they will not produce good waves, and sometimes that's not even enough. So if you're noticing you're having a difficult time getting very clear lines or any lines at all with your ECG machine when it's on, one trick is to place ultrasound gel or some other lubricating gel on the skin and then put the leads on top of that. So you have the skin, then you have a layer of gel, then you have the lead itself. By doing so, you can get a much better flow of electricity out through the body, through the skin, through that gel, to the metal on the ECG lead, and then into the machine. Now let's talk about some myths. One myth is that limb leads must be placed at the ankles and wrists. This is not necessarily true. While they are identified as left leg, left arm, right arm, and in the videos depicted as being at the wrists or ankles, you have some options for the position of the actual limb leads. As long as the limb leads are at the same location in the lower extremities or at the same location in the upper extremities, left and right, you can position them elsewhere. For example, you can position the leg leads, the lower extremity leads, on the calves. You may position the upper extremity leads, the arm leads, at the forearms, or even on the humerus, close to the shoulder. Why is this important? This is important especially in patients who have had amputations from trauma such as motor vehicle accidents or landmines. Do not think you can't do an ECG in patients who have had amputations. You can. What is important, though, is that within each region, the lower extremities, for example, if you move up to the calf because a patient does not have an ankle, on the left leg, then you need to do the same thing on the right leg. If you move up to the area close to the shoulder on the left arm, then you need to make sure to do the same thing on the right arm. And some ECG technicians say that the clearest images are actually produced when those limb leads are closer to the torso. So, practice with a variety of different positions. See what works best with your machine. Finally, there is a myth that if you tell patients in a command form that they must hold still, you will get the clearest image. That may work for some patients, but for other patients, telling them to hold still can make them very nervous and, in fact, interfere with your ability to get a clear ECG. When patients are moving too much, ECG lines are very unclear. They're very wavy. You get artificial waves on the ECG, not the PQRST, but other waves simply created by the movement of the patient themselves physically. So in order to get the clearest image, patients do need to hold still. But there are other methods for getting them to hold still aside from asking them to be still. For example, we saw in the video lying patients supine. If you lie them supine, they have less opportunity to move. You're more likely to get a very clear image. Further, asking patients while supine to relax and breathe deeply and slowly can be a very effective method for getting excellent images. So remember, asking patients to hold still, especially if you have them sitting up, can make them more nervous and move more. So don't do your ECG with them sitting up, and try to find the best method to relax your patient while supine and getting an ECG. If you do that, you will have the clearest images possible. So this concludes our segment on ECGs, how to do an ECG, and the case-based educational curriculum presented by Stanford Emergency Medicine International and URC, with funding provided by USAID. Thank you very much.